Good morning, everyone. My name is Jenna Webb. I'm with SHA Communications, and I'll be the moderator for the call this morning. In the room with me is our Chief Executive Officer, Scott Livingstone, and we also have a number of individuals on the line. But to deliver opening remarks prior to questions and answers, I'll turn it over to Scott.
Thanks, Jenna. Good morning, everyone. I'd like to start by acknowledging that I'm joined today by three members of the SHA leadership team: Dr. Susan Shaw, the Chief Medical Officer, Dr. Julie Krasnowski, our Senior Medical Health Officer, and Mr. Derek Miller, our Command Lead of the Emergency Operations Center. I'd like to begin by thanking the thousands of healthcare workers across Saskatchewan for taking care of our residents each and every day. Your sacrifice and continued work during this pandemic has been immensely humbling. I'd also like to thank our patients and residents for their ongoing understanding and patience through this time period. COVID-19 presents challenges we can't always avoid, so we appreciate your support. Even as our province resumes more activities, we know your help will still be necessary to fight against this virus. One of our first priorities as a healthcare system since we began has been to protect our most vulnerable patients and long-term care residents from contracting COVID-19. One of the first steps taken in response to COVID-19 was the public health order issued by the Government of Saskatchewan early in March to temporarily restrict visitors to our facilities across the province, except for compassionate reasons. Our initial response required a fairly narrow definition of compassionate for grounds for visitation, and given the devastation that has occurred in other provinces and outbreaks in healthcare facilities, particularly long-term care homes, this was a necessary step. And while we need to protect our patients, residents, staff has not changed, we also recognize there's a need to find the right balance between physical safety, mental health, and well-being. We know that illness and age can make time an especially precious commodity for many in our care. So together with the advice from patients, residents, families, we are finding the right path forward. In the upcoming week, our facilities will be implementing expanded guidelines for family presence within our long-term care facilities. This will adapt our visitation criteria to include more than those needed just to support the direct care needs of residents. Starting immediately, our long-term care facilities can permit visiting for support persons able to address unmet quality of life needs of our residents. Full implementation will come in the following week. There will be strict processes and protocols to guide this and support physical safety. We're also adding clarity around outside visitation at our long-term care homes. We look forward to working with families to schedule and create outside visits for their loved ones and keep care and safety a priority and ensure that we accommodate all of our residents who want to see their family outside. We're also providing clarity to family present guidelines for inpatients, outpatients, and emergency care. These and other updates to our family presence policies are all the result of work of our family presence expert panel. Patient and family advisors, along with public health, infection prevention and control experts, have been providing ongoing guidance to support family presence during COVID-19. I'd like to thank everyone involved for the work that they've done. You are helping us make a difference in the lives of our patients and residents. These important steps to help us find the balance between opening our doors a little more while still having the safety of our patients and residents and clients is up front of mind. As an additional safety measure, we will also be providing all outpatients and family members or support persons with a medical grade mask and asking that these individuals wear the mask while inside SHA care homes and facilities. I'd like to also take the opportunity to remind folks that we have broad and growing testing criteria for people across the province, and this broad testing criteria could also be used to help alleviate concerns family members may have when entering facilities. So please reach out to your family physician, nurse practitioner, or 811 to see if you meet those criteria and would require a test to add additional layer of safety. These policies are not our norm, but are designed to meet the demands of an unprecedented situation. Saskatchewan is recognized as a leader in patient and family-centered care, not only in Canada, but around the world. When Accreditation Canada came to us last November for their site visit, they explicitly recognized the organization for our system-wide focus and on a culture of patient safety. We not only met all the criteria in place by Accreditation Canada, but Accreditation Canada went further by citing our extensive efforts since the creation of the SHA to further expand our commitment to people-centered care. For us, people-centered care doesn't just mean a commitment to the patient or resident, but also the family and loved ones of those individuals. Saskatchewan was one of the first integrated healthcare systems to adopt a system-wide open family presence policy. This is why I'd like to emphasize that our usual policy outside of COVID is open family presence, and also that we will continue to review risks and so that we may regularly return to this practice as soon as it's safe to do so. This is part of our balance, addressing an unprecedented pandemic while slowing returning to a new normal. This month, we're going to take another step towards that new normal. Since early March, we have had in place our Emergency Operations Center to ensure a coordinated and comprehensive response to COVID-19 pandemic. I'm very proud of the work that's been achieved over the past 3 months to adapt pandemic plans for the realities of COVID-19 across this province. Together with our key partners, the Ministry of Health, Saskatchewan Cancer Agency, and others, we have established offensive and defensive strategies for containing, mitigating, and delaying the virus. With this groundwork well established, we are now turning our attention toward integrating this work into our daily operations of the SHA, as we expect that we will continue to need to respond to COVID-19 for some time. So next Wednesday, we will be transitioning this work of the Emergency Operations Centers back into our regular operational structures. We also recognize that there will remain an ongoing need to centrally manage public health matters related to COVID-19, and that's why we'll be activating a Public Health Incident Command Center on June 8th to centrally coordinate information sharing, decision-making for key public health functions of our pandemic response. The new structure will have a narrower focus, supporting outbreak response, as well as activities like surveillance, contact tracing, public health inspections and enforcement, as well as population health promotion. At this time, I'd like to personally thank Derek Miller, who's on the line with us today, who has been sitting as our commander of the Emergency Operations Center during the time period when we've been managing our first phase of COVID response. Derek has done an exceptional job leading leaders throughout the system through the most challenging situations impacting Saskatchewan healthcare in my history. I'd also like to take the opportunity to thank Dr. Julie Krzyzanowski, who's also with us today, for her leadership in leading our offensive strategy and ensuring our response is grounded in what matters most, and that's providing the most effective care we can to the people we serve, particularly those who are most vulnerable. Derek and Julie are both very humble, so I know that they would want me to highlight that all the people that worked around them who deserve the lion's share of this praise. So on behalf of myself, the Board of Directors of the SHA, Dr. Shaw, and other members of our executive team, I want to say thank you to everyone at the SHA and our partners who helped us with our COVID response to date. We would not be as well prepared as we are without all of the work that you have done. I want to emphasize that at any point that there is the potential for our health system to be overwhelmed by COVID-19, we will react and reactivate our Emergency Operations Center to centrally manage activities. I can't stress enough that this is not a return to normal, rather our new normal, where COVID will remain an operational priority for the health sector for months to come. I've said this before, that COVID-19 has not gone away, but thanks to the work of people like Julie, Derek, and our EOC team, and the thousands of healthcare leaders across this province, we are ready to serve the people of Saskatchewan when they need us. Thank you, and I'd open up the floor for questions.
We'll take questions both in the room and on the line. Let's start with a question on the line, please.
We have Lisa Schick with CJME.
Hi. So thus far, has had a pretty good, record when it comes to long-term care compared to other provinces. So are there any concerns that opening things up like this could jeopardize that?
Well, I think it's fair to say that doing anything that takes us back towards a new norm holds some risk, because we know COVID is still with us. But based on what we're seeing in the province today with low numbers and the management of outbreaks to date, as well as the needs of clients and residents and patients in our facilities, we feel that it's warranted to very cautiously, slowly, under direct supervision with well-organized policies and planning to do this. We have heard from many, many people from across this province of the hardships that have been created by the absolute lockdown of long-term care facilities and our ICUs where we have vulnerable patients. And we know that we need to start opening up, because that is not sustainable. And we would point to other provinces across the country that are doing the same. And I think the important message is we need to do that safely. And we also need to do it in a way where we're monitoring it very, very carefully. And the only other thing that I would say is to remind folks that, we know, and Dr. Shaw mentioned this, I believe, yesterday, 30 to 40% of folks are asymptomatic out there in community. That includes healthcare workers, and we've had healthcare workers, even though we've cohorted the staff in our facilities and we're going in and out of these facilities on a daily basis, interacting with their families, and we haven't seen major concerns arise over COVID. So we think that it's the right time to start reopening with cautious and important safety protocols across the province, but we do think that it is time to do so.
Is there a follow-up, Lisa?
Yeah, I guess what would end up happening, I assume that this, as with some of the other things that are opening in the province, if there were things that happened like more outbreaks or numbers going up quite a bit, that things would be pulled back. Is that the case? And if that is the case, I guess, is there a benchmark for what would have to happen for these loosening of restrictions to be pulled back?
So you're exactly right, Lisa. I mean, we would, if we were seeing something like a major outbreak in a facility where we were seeing facility contacts and facility uptake of the virus, that we would have to back off. Is there a target? No, because it's going to be dependent upon the situation that arises. Similar to community-based outbreaks, we know we're going to experience them. The importance is jumping on those cases as quickly as we can, identifying where they occurred and why with aggressive contact tracing, and trying to mitigate the spread of the disease as quickly as possible. In long-term care, because of the things we've already got in place to protect folks with respect to continuous masking, the cohorting of staff, we will still be maintaining physical distancing, good hand hygiene, and all those things. So collectively, is there a target that says when we would lock it down? No, but because it's going to depend on the situation that we see, just similar to what we're seeing across the community as well.
We have a question in the room.
So we've heard concerns from the family of sorry, I have a bit of a stutter, of Samuel Uko, that they weren't able to accompany him when he was seeking mental health care, and I was wondering to what extent that tragedy and the reports that are surrounding it played in the kind of relaxation of some of these rules, particularly the inclusion of the term mental health disability in that expansion, and whether you think that with these new rules that what happened in his would not happen again.
Okay. So first of all, I'd like to again extend our condolences to the family of Samuel and his loved ones over this tragic event. I wouldn't say that event, because it is currently under investigation, and we're working with the family to answer their questions around that investigation, and I won't speak specific to that. But when I referred to the mental health and well-being aspects, I was actually not excluding folks that would attend emergency rooms or other services for mental health disorders, Arthur, but what I was referring to is just the general state of our residents who have been locked down for so long, particularly residents with dementia and other neurological disorders like Alzheimer's disease that really depend on that day-to-day contact with loved ones to receive that appropriate quality of life and care. So with respect to our considerations for changing the policy, that particular incident, and I won't speculate on what the outcome would be, had very little, if anything, to do with it.
Is there a follow-up?
Yeah, I do have a follow-up. So just a few things on the sort of LTC expansion here. Can you explain in a bit more detail what you mean by, sort of unmet
Quality of life needs?
Quality of life needs? Like what would determine when that would be considered to be an appropriate visit?
Well, the first thing I would say is that all the policies and the new guidelines will be posted online, and there's a lot of detail that's currently involving, including questions from our own teams in long-term care on how do you really define that, and we're still working through some of the nitty-gritty details. But we have heard, for example, we had a town hall with patient and family advisors and teams across the province, over 500 participants, and we led that off with a patient story from a gentleman whose wife is in long-term care with Alzheimer's disease, and I thought he very eloquently went through some good explanations of what care would be like without his presence and some of the concerns that they would have in that precious time left. I don't have all the details for you, Arthur, but I can tell you that they will be documented on our policies and flow diagrams so that we can apply these policies consistently, as well as use, you know, not just the policies, I mean the patient and family specific situations. So for example, one of the things I can tell you that's been limited is animals that are used for therapeutic benefit, you know, so that's a good example of you know, oh, what's the term I'm using for? But they're the trained dogs for supporting folks in for either mental health or physical disabilities. We've been restricting those. So that would be an example of one of the quality of life measures for those individuals to get back to more normal activity with that in those circumstances. Susan, I'm not sure. Do you have anything you want to add for Arthur's question?
Yeah, I think that it's finding that balance between working through the public health measures and order that still are in place and are still necessary to ensure safety as best as we can for the people we serve and the people who work with us, while also recognizing that health is much more than physical health. It's emotional, spiritual, and mental health as well. And when quality of life is important to all of us, and it's perhaps even more important for those who are living in a care home for whatever reason they need to be. So we're really asking that families work with the care staff to determine what's best for their loved one, and working within the guidelines and the public health measures identify. So it could be someone who needs reorientation, or someone who has memory loss and has a better quality of life from having a more constant, you know, a more presence of a loved one. And it's really, we're trying to create some limited flexibility while recognizing there's always going to be that tension, sadly, and between what we want to have happened and what needs to happen right now. The other thing I just wanted to add to there, or I think it was Arthur asking the question, we have expanded our abilities for people seeking emergency and urgent care to also have somebody with them when there are problems or situations like visual impairment, memory impairment, or confusion. And these are things that were being considered by the expert panel in the weeks prior to today's announcement. And it really is through good conversations and discussion with patients, families, and staff that we've been able to, I think, find that space while still living within the public health measures, being able to be more able to recognize how to support people when they need our support.
We'll take another question on the line, please.
We have Mark Smith with CTV.
Hello, I'm just wondering what type of screening will happen for family members or support persons when entering into a SHA facility or long-term care home.
Susan, do you want to take that one?
Yeah, it's the same screening assessment that's used for staff and students when they come into our building. So it is, have you been out of province? Have you been in, you know, the examples are, they're on the Saskatchewan.ca website, but it's, do you have symptoms? Have you been in contact with a known person? Are you coming from an area where high, that's been identified as a community of where there is outbreak? And I don't know, actually, a good question that we can follow up on is there a temperature screen? I think there would be temperature screening also, because really it's finding that balance of making sure we're identifying people who could potentially be introducing the virus. So it's the same screening process that I go through when I come into the hospital as well, or into a building. And I'm seeing from Derek that he's nodding, which means that temperature screening is part of the screening for our visitors and our families as well. Thank you, Derek.
Do you have a follow-up, Mark?
Can you give us more details about the family presence expert panel, who was on it, and kind of what consultation went into developing these plans?
Sure, that's under Susan's leadership and portfolio, so I'll turn that over to Susan again.
Yeah, so an expert panel was struck, and I want to say it was about 4 or 5 weeks ago. Time, as you know, under COVID seems to follow different rules. But we really had patients, people living within long-term care, family advisors, representatives from the Health Authority's leadership from internal medicine, maternal and children's care, continuing care, long-term care, mental health, infection prevention and control, the quality of care coordinators, ethicists, representatives from First Nations and Métis Health. We were very lucky to have one of the vice presidents of the Institute for Patient and Family-Centered Care, which is a North American, if not world leader on patient family-centered care, medical health officers. So we really tried to have a group of, I want to say at least around 20 people who met on a weekly basis, looking at where are we right now, what is the evidence, what are other health systems doing in Canada and around the world to address this tension between safety within a public health measure and recognizing that physical health is much more than physical health, and patients and families and we're all better when we work together and when we have families present as much as possible.
We'll take another question from the line, please.
We have Stephanie Taylor with the Canadian Press.
Hi there. I'd like to know what spurred the need to revise guidelines around who gets an accompanied person when seeking emergency care. Specifically, what has this been expanded to include?
I'm not sure I understand the question, Stephanie. Can you repeat it for me?
So really we're looking at, over the days ahead, sorry, Scott, is that, and I'm sorry, I just apologize, I'm flipping to the right page because we do have all of this shared on the Saskatchewan.ca website. And for urgent care, inpatients and outpatients, it's really looking at when a person needs additional support because of specific challenges that could result in compromised understanding, decision-making, or mobility, that they'd be able to have one person accompany them to help both navigate the system, which and be that resource person for the person seeking help. And like I said, we've been looking at right from day one, we knew that when we had to live within the public health measures that were given to us, that we needed to be able to be fairly limited at the start because of the concerns for safety, for containing, mitigating, and delaying the spread of COVID. But that as we've learned, not just in Saskatchewan, but around the world, how to do that well. I think we have learned how to do that well in Saskatchewan, that it's the right time to be expanding and working, again, within the public health measures to expand the definitions of what compassionate means in Saskatchewan, and how do we actually do that in a consistent way. It's going to take some time, I think, for our staff to be able to actually learn how to do this. It's relatively easy to stop something. It's really hard to reopen and restart something well in a way that is consistent and fair. So one of the things that I think is important to flag is that we are absolutely committed to expanding these definitions, and it will take, I think, time for us to learn how to do it well. We have lots of relatively simple but actually quite difficult questions that need answering, and we will find the answers together. But it's really over the next few days and weeks, I think you'll see new ways of having families present in our building.
Is there a follow-up, Steph?
Yes, there is. Before today, was mental health disability defined as the criteria for allowing somebody to have a support person accompany them in an emergency or urgent care situation?
Susan, do you have?
I think we'd have to follow up to make sure that I have the right language. I don't have our former language in front of me, and I think that would require follow-up, Stephanie.
We'll get back to you on that one, Steph. We'll take another question from the line, please.
We have Adam Hunter with CBC.
Hi, I want to know just what are the biggest concerns you've heard? You mentioned the town hall you had. What are the biggest concerns you've heard from people in long-term care on, the quality of life and not having that visitor present during this time?
Well, I think the vast majority of the concerns are related to, that I've been receiving, are related to those individuals with neurological disorders, particularly dementia and Alzheimer's disease, where we know major changes to their care have substantive impacts on their day-to-day quality of life. And many of the concerns that I've received, some of the concerns that were raised yesterday on the call, were specifically around patient and family loved ones who are concerned about not being there. You know, literally, we have husbands and wives that have been attending facilities daily to support their spouse and or loved one with the day-to-day activities, and that's been by far the single biggest concern, and not just the angst of knowing what's going on, but their worry about people, I would say, regressing or moving backwards in their care because of not having that regular visit from the loved one that had been so essential to the day-to-day care. And that, by far, I would say would be the biggest one that I'm receiving. I'm not sure if Susan has anything to add to that.
No, those are the same concerns that we heard through both the stories of, through the expert panel and through the correspondence that we have received. It's that loss of time and connection with their loved one. And I think we all share sadness about that, and we recognize that that's true.
Is there a follow-up, Adam?
I'm wondering if you can give me some more specific timelines on when this will roll out in the different places like ERs, long-term care, people in intensive care, and also the specifics on how it's going to be determined whether a resident does need that support person, because I can foresee probably a situation where someone says, well, I need to be there, I've been there every day, and maybe they don't fit under the criteria, depending on what care home they belong to.
Okay, well, I'll start, and I would say that with respect to the timing of the criteria, because we've already developed the criteria and there's some nuances that we have to work through because of the 270 facilities and the staff across the sector with respect to making sure that we're implementing consistently. I can tell you that the criteria was already used last night to support a family caring for a palliative patient in the family, and the expanded criteria was used to help support that family. That, as I said, the criteria can be used immediately. But what we're working towards is how do we make it consistent across the province throughout all of our facilities, and ensuring that everybody is aware. Now, with respect to the flexibility that the policies will have, who defines an essential individual isn't going to be left up simply to the SHA, and we will have mechanisms to help support families. As an example, like we did last night with the family request to expand the policy, and through the work of of staff on the ground, that happened. So we don't see that there is going to be a process of arguments. We hope the process is flexible, and I just want to remind folks that, as we open this up, those same protections that we've already put in specifically into long-term care, the staff screening, the cohorting, the continuous masking, and the social distancing, those things are all still in place inside the facilities. What we're doing is allowing more patient and family loved ones coming in to visit under criteria that would also protect themselves and the staff. Susan, did you have anything to add about the timing?
Yeah, I think that it's immediately that long-term care facilities can start, working with families to identify what that support person, what the quality of life issue that a support person can help meet. And it will take a few more days, I think, to roll out across the other parts. We actually purposely chose long-term care first because that's where most of we have, I think it's over 9,000 people living in long-term care buildings, and that's a large group of people, and that's where most of our concerns that we want to address are. So we've purposely prioritized what we think are the greatest needs. We've also added a task team that can actually provide support to both families and staff who are working through what could be uncertainty. We want flexibility within the parameters of the public health measures. And if support is required, there's a way that this is a new support to our staff. There's a way that they can reach out either through email or through a hotline and ask questions and get guidance from our client and family experience team to actually allow for better decision making. And I think through good conversation, the public and our families have really been very supportive and understanding and have been asking, can you help support this in a new way? And that's what we're finding.
We've got one last question in the room.
It sounds like when it comes to the new LTC rules, some of this could be kind of, complicated to work through on the ground. It could involve a lot of difficult decisions and a lot of precautions for staff to take as they guide families to visit their loved ones. I was wondering how staff are going to be expected to kind of juggle that added workload when they're already facing added pressures because of COVID-19, and whether any additional resources are going to be made available to them to facilitate that work.
So a good question, Arthur, and it's one of the ones that is being addressed as we actually talk about how we properly implement this inside the facilities and how we coordinate staffing to accommodate the visits. I just want to remind we are dealing with a number of new restrictions inside those facilities, but with the cohorting of staff and the consistency of staff, as well as the fact that pre-COVID, with an open family presence policy across the organization, visitors were coming into those facilities each and every single day, unmonitored, in bigger numbers, which would also put stress on the staff. So we think, that not to say that the new expanded policy won't have some added implementation issues, but it's one of the reasons why we've had such broad discussions across the organization, including yesterday, as well as the importance of having standardized policies, but not standard in the way that they're also flexible, so to give those teams on the ground the ability to be flexible within the policies and procedures that is established to implement. So do we think that there may be some increased staffing required to implement across? Yes, there might be, for sure. And we'll be working with facilities and managers in long-term care and directors in continuing care to actually work through that as the policy evolves.
Just while I have you here, I would just like to ask for some sort of updates on some of the other aspects of the resumption of services plan. Can you tell us how things are progressing in terms of reopening rural ERs, and further in terms of, kind of bringing surgeries back online that have been postponed as well, particularly what kind of bottlenecks you're now expecting in terms of all these surgeries coming back online?
Okay. So I'll start with Derek's support and probably Susan's support. So we have been posting online since the resumption of service phase 1 plan starting on May 19th. I believe there's been over 300 services restarted across the SHA, primarily focused on everyday healthcare services, including surgery and other things. So with the expanded surgery, as you know, we've been targeting sort of a 75-25, 75% outpatient, 25% inpatient surgeries to start working through those folks with most urgent need, but also at the same time looking at what we do on the elective side. So we are posting that, and it's continuing to evolve as we open up. We've been open now since May 19th. We haven't seen any major COVID challenges as a result, with the exception of our business changing to accommodate social distancing and all those other safety features that we have in place to prevent COVID spread in our facilities. So we still haven't, what I would say, have a great handle on what ultimately our new normal will be, because as we continue to expand services, continue to abide by our COVID restrictions and keeping our staff and patients safe, it continues to be a moving target. And again, today is another good example. As we open up family presence across facilities, we're adding another factor into the reopening of the healthcare services, which is a needed thing to do. With respect to bottlenecks, one of the things that we put in place, Arthur, as the services continue to expand, is that each and every service requires a safety check, so that before we would actually allow that service, wherever it is in the province, to start opening up again, is that we have the teams on the ground have assured us that they can meet the safety requirements associated with COVID and go on to our regular business, regular under COVID. With respect to how we're going to continue to open up, I think I could probably pass it off to either Susan or Derek to expand on what might be next. But I just wanted to highlight, each and every day you see new services have been coming up and running across the SHA as part of that phase 1, and we continue to see some challenges on the ground with respect to COVID restrictions, but it hasn't stopped it hasn't stopped the services from reopening as long as we are focusing on the safety aspects of that provision of service. Derek, did you have anything to add?
I don't have anything specific. Perhaps Susan has comments.
No, I think that the emphasis has been purposefully on the everyday healthcare services. These are the services in the community that help create health and keep people well, while also recognizing there are people waiting for diagnostic tests or procedures and surgery. And so it's restarting while keeping in mind how to always be maintaining capacity for both COVID and non-COVID patients, that the public health system must have the capacity to continue the testing strategy and for contact tracing, and that there must be PPE available for all staff, patients as required, and visitors now that we've added to our, to our outpatient list there. So it's really about, a colleague was just reminding me, healthcare is a complex system, and we now have a new level of complexity added because we're recognizing that COVID is here and it's staying here for the months to come, and the new normal is, they're not bottlenecks, they're actual real challenges that need to be managed and mitigated.
That's the last question for today. Thank you very much.
Okay.